Okay, you've got Greg.
In his bed.
Hi. Okay, I think you're looking. All right, I think you're looking at Dr. Sharma and myself. Hi, my name is Sunil Varghese. Thank you for joining us again for the second of our series of talks related to COVID-19 pandemic. For those of you who were able to join us last week, we had Dr. Sharma, who talked a bit about the epidemiology and the impact of COVID in our local area. And then we had Drs. Hallman and Desjardins giving us a clinical update on the management of COVID positive patients. This week, we're going to focus a bit more on the granular levels of what is COVID, sort of the infectious disease issues, the science regarding the testing and whatnot. And then we're going to jump into the impact of COVID on infection control processes. So for the first part of our talk, we have again Dr. Karan Sharma, who's a friend and colleague here at the Queensway Carleton Hospital and ID consultant. We'll be giving you that. And then after that, we're going to jump to Dr. Greg Rose, who is sitting on his beautiful patio right now, who's also a friend and colleague here at the Queensway Carleton Hospital and the medical director and chair of our Infection Prevention and Control Committee. So with that, you should be seeing Dr. Sharma's talk, and I'm going to hand over the mic to him. Thank you very much. Sorry, I did forget to mention that if you do have any questions, we'll try and take some questions after Dr. Sharma's talk. If you could just type them into the chat function, and I will serve as moderator to read them out. Okay, Dr. Sharma, please. Sorry, just to give us control, do we have control of the screen? I don't think we have control of the screen right now. So you have to request control. Okay, we're not getting full screen. I don't think we have full control of the screen, but maybe Catherine, if you could just full screen the presentation and then perhaps advance it for us as we require. Thank you.
Okay, hi. My name is Karan Sharma, one of the ID physicians here at the Queensway Carleton Hospital. So giving a COVID-19 update, if you don't mind going to the next slide. No disclosures. So the top outline is basically pathophysiology of COVID-19, transmission, testing modalities, and potential treatment options. Next slide, please. Okay, so virology and pathophysiology. Next slide. So just before we get into the talk, there are a few things like SARS-CoV-2 is the name of the virus itself, whereas COVID-19, coronavirus infectious diseases 2019, is the name of the clinical illness. But for the rest of the talk, we'll refer to both entities as COVID-19, just for simplicity. Next slide, please. So coronavirus is named so because of the crowns you see, which are the S proteins. This is an electron microscope picture. Those are the S proteins that look like crowns around the virus. Causes common cold in humans. It's around all the time. When you look at the human infection, really it's alpha coronavirus and beta coronavirus that cause it. And next slide, please. And what's interesting is that so all the SARS coronavirus, MERS coronavirus are from the beta coronavirus family, and they usually have an animal reservoir and an intermediate host. So when you look at MERS coronavirus, the animal reservoir was bats, the intermediate host was camels, and the humans were the incidentary host. Whereas when you look at the original SARS coronavirus, it was bats, and then the palm civet, which is a small mammal, was the intermediate host. For this novel coronavirus, We know the bats are the original reservoir, but we still don't know what the intermediate host is. But very similar conditions to SARS coronavirus and MERS coronavirus. Next slide, please. So when you look at the timeline, coronavirus was first actually found in 1966. SARS happened in 2002, MERS coronavirus in 2012, and COVID 2019 happened in 2019. Next slide, please. So when you look at SARS itself, it was 2002 to 2003, severe acute respiratory syndrome, 8,098 cases, 774 deaths, mortality was around 9.6%, and involved 26 countries, including Canada. And this is the palm civet, which is the intermediate host. Next slide, please. When you look at the MERS coronavirus, so this was in 2012, predominantly, as the name would suggest, in the Middle East, around 2,500 cases, 858 deaths. Mortality rate was very at 34% and involved 27 countries. Next slide, please. So because the original SARS happened in the winter months in a wet market, China CDC actually has a protocol where if you have undiagnosed pneumonia without a pathological diagnosis, you do run multiplex pan-coronavirus PCR. And so given what they found was there was 7 patients admitted to the ICU in Wuhan Yinjin Hospital, and they weren't able to find an etiological agent. And 6 out of 7 worked at the Wuhan wet market, and they did a pan-coronavirus PCR, given the similar circumstances to the original SARS, and 5 of the samples were positive for this novel coronavirus. Next slide, please. And as a result, they were able to get a phylogenetic analysis of the coronavirus. And as you can see, like here's the SARS coronavirus, here's MERS-CoV. So it's kind of close to bat coronavirus, but it's this complete separate entity. And within that entity, it's actually pretty diverse. It's not a one virus itself. It seems like there's almost multiple strains that are happening because it's mutating. Next slide, please. So when you look at further phylogenetic analysis, you actually have 2 different haplotypes. You have an L haplotype, which was originally more prevalent, more common in the early outbreak, and most of the cases Wuhan were with this. And then you have the S haplotype. Because it's an RNA virus, it's got a very poor, it's got a high mutation rate. So it actually is kind of, it's not staying constant, so to speak. It's actually diverging. Next slide, please. So when you look at the how does this virus get into the cell? So this was a study published in Nature, and basically what they realized that it binds to the ACE2 receptors that are located in type 2 alveolar cells. And the thought is that this the spike protein, which is this spike over here, binds to the ACE2 receptor, and then it kind of swallows the cell inside, hijacks the machinery, goes into the endoplasmic reticulum, and then is kind of pumped out of the cell as well. It's the same receptor used by the SARS coronavirus in original one. Next slide, please. Now, what's interesting is that ACE2 receptors are also expressed on nasal and goblet cells. So when you look at nasal cells, you have goblet 1, goblet 2 cells, and sedated cells, and all 3 of them have a high level expression of ACE2 receptors, including also cells in the lower airway and the lung parenchyma itself all express ACE2 receptors. So these are potential sites where the virus can enter into the body. Interestingly, ACE2 receptors are also found in the cornea. So there have been reports of conjunctivitis with coronavirus. So that could also be serving as a portal of entry. Next slide, please. Now, to complicate matters even more, ACE2 receptors are also found in glandular cells of gastric, duodenal, and rectal epithelia, which raises the possibility of fecal oral transmission. Although not completely proven, but given their receptors present, it is a possibility. Next slide, please. So in this study in New England Journal of Medicine, what they looked at was 7 autopsy results of lungs from people who had COVID, and what they found was few unique things. One was severe endothelial injury and widespread vascular thrombosis with microangiopathy. But they found this new type of angiogenesis called intussusceptive angiogenesis, which they think is kind of unique to COVID, although the sample size is very small. The severe endothelial injury and widespread vascular thrombosis can be just seen with ARDS. Next slide, please. And so really, when the 3 main ways where COVID really can kill a person. One is its hypoxia respiratory failure, where the pneumocytes have viral cytopathic effects, which means that there's direct virus damage that happens. And autopsy shows lymphocytic pneumonitis, fibrinous organizing pneumonia, and diffuse alveolar hemorrhage. The second thing is the cytokine storm. So classically, as we've learned, you get the illness and it's a grumbling illness for the 1 week, and the second week is when you kind of deteriorate with the cytokine storm with high CRP, D-dimer, LDH, and all these inflammatory markers, ferritin. Very similar to hemophagocytic syndrome, and then that cytokine storm kind of leads to ARDS. And the third way is DIC, or disseminated intravascular coagulopathy. D-dimer is up, the lung itself shows multiple microvascular thrombi, so that's the third way where you can, COVID kind of damages your body. Next slide, please. So transmission. Really, it's so far the evidence all points towards direct person-to-person transmission with close-range respiratory droplets with contact with mucous membranes, also touching of infected surfaces and then touching mucous membranes. Airborne transmission remains a controversial issue. So hopefully, I can address that in the upcoming slides. Next slide, please. So this study caused a huge stir. It was published as a letter to editor in the New England Journal of Medicine. What they did was basically they took COVID-19 and they used an industrial-side aerosolizer, and they generated aerosols from it. And they found that, yes, indeed, viable aerosols can stay viable for up to 3 hours as aerosolized particles. Also, they found that this COVID-19 virus can stay on copper, cardboard, stainless steel, and plastic as well for a prolonged period of time, up to 96 hours, if not more. So what this study tells me that is if you artificially generate aerosols from COVID-19, it can generate aerosols, but it doesn't explain anything about the natural history of COVID-19. Next slide, please. So this was an interesting study that helped to look at the transmission properties of COVID-19. So this was a COVID-19 outbreak associated with air conditioning in a restaurant in Guangzhou, China, and there were 10 persons for 3 families diagnosed with COVID-19. So on January 24th, the index case was having lunch with his family, and there were 2 other families sitting on either side of the table. The index case started developing symptoms on January 24th and got tested for COVID and was positive. And by February 5th, the index case and 9 other people, so total 10 people, had COVID, including 2 families at the neighboring tables. The distance between the tables was 1 meter, and the 2 families were overlapping by a period of 53 and 73 minutes respectively. Next slide, please. So this is kind of the schematic. This is the air conditioner. This is the table A. This is the index case over here. These are the family members who got infected. This is family 2, 3 people got affected here, and this is family 3, 2 people got infected. Interestingly, none of the other people got infected. So if you go to the next slide, please. So there were 91 people in the restaurant at the same day, including 83 customers and 8 staff members. The rest 73 customers were quarantined for 14 days, and they were tested for COVID-19, which was negative, and nobody developed symptoms. So you would think that if it was aerosolized, and if the aerosolization lasts for a minimum 3 hours, then not only would everybody in that particular time period on the tables be infected, but also more than 10 people be infected because it was aerosolized for more than 3 hours. But that doesn't. But given the results of this, it doesn't suggest that. It suggests that it is droplet transmission, considering the tables were close to each other. Next slide, please. The second question becomes the infectivity. So how long is a person infected for? When do they start becoming infective? How long are they infected for? So this was an interesting study published in Nature where they took 9 patients with COVID, and they did viral cultures as well as PCR on them for up to as long as the PCR was positive. And what they found was amongst the 9 people, the peak viral load was at day 4 of symptoms. But beyond day 8, they were not able to culture the virus. Even though the PCR was positive beyond day 8, the virus was not able to be cultured. Interestingly, the PCR from stool was positive beyond day 8 and beyond up to day 10, but it was never culturable. So what does this tell us? It tells us that probably the virus you have very high viral loads in the initial course of the disease, but really after day 8, the virus is not culturable. You'll have PCR detectable, but that doesn't necessarily mean that there's a live virus because you're probably picking up fragments of the RNA. The only caveat from this is that 9 patients had mild disease. So it's possible that, with people with severe disease, that the virus is viable for longer. And it was a small study, but next slide, please. So when they looked at how long is the PCR positive for mild versus severe cases, this study was out of 76 people admitted to Nanchang University. And what they found, so blue is mild cases and and red is severe cases. So they found that mild cases had early viral clearance, by 90% tested were negative by day 10, where severe remained positive beyond. But again, the clinical significance is not clear. So does that mean that you had a very high viral load, severe illness, and then you're just picking up more fragments of RNA as time goes on? The previous study was suggested by day 8, it's difficult to clear the virus. So, but for severe disease, the viral PCR can be detected way beyond 10 days. Next slide, please. So then the question becomes, okay, what if you're not symptomatic? Are you still able to transmit the virus? So this study out of Guangzhou Hospital looked at 77 people, and they found that mean incubation period was 5.2 days. And when they did this modeling study, they found that the infectious period really started around 2.3 days on average before symptom onset. So this helps us figure out what the infectivity is, right? Likely it's 2 to 3 days before the onset of symptoms and maximum at day 4 of onset, and then kind of tailors off by day 8. So it peaked at 0.7 days, and based on the study, they estimated their pre-symptomatic transmission was around 44%. So that is probably where most of the transmissions occurred in the pre-symptomatic period, where there's a high viral load and no symptoms whatsoever. Next slide, please. So then the question becomes, are there asymptomatic infections present? Yes. So there have been multiple small studies published. The one was this, you guys might remember the Princess Diamond cruise ship, where 17% of the population tested positive, and greater than 50% were asymptomatic at the time of diagnosis. Most of them eventually developed symptoms in the next week, but the modeling studies suggested that 80% were true asymptomatic cases, as in they didn't develop any symptoms throughout the course of the illness. And the second one was looking at a nursing home in Washington State, where 56% were positive at screening, but were asymptomatic. But amongst those 27 people who tested positive, 24 did develop symptoms in the next 7 days. And the third study was looking at 2 New York City hospitals in the obstetric unit, where they screened everybody for COVID-19. And this was at the height of the COVID in New York City, and they found that 29 out of 210, that's 14% of the asymptomatic women were positive at presentation. So asymptomatic presentation is definitely possible. It seems most of those people do develop symptoms eventually, but so there's a significant minority that do not develop symptoms at all. Next slide, please. So transmission summary, it was seen the current evidence would suggest that predominantly it's contact and droplet transmission. Airborne generation is possible, hence we should be using N95 masks or respirators when you're doing an aerosolizing generation procedure. Infectivity is likely 2 to 3 days before symptom onset, and it's up to day 8. It's unclear if it's beyond that, because you can't culture the virus, but you're detecting fragments of DNA. Maximum viral load, hence the maximum infectivity, is likely in the first few days of symptoms. And asymptomatic transmission and asymptomatic disease are possible. Next slide, please. Okay, so testing. So as of today, we just got, I'm sure you guys got the email too. As of today, Ottawa is in line with the Public Health Ontario, where all symptomatic people, even with mild symptoms, should get tested. In terms of asymptomatic people who are concerned that they have been exposed to COVID qualify for the test, and people who are at risk of COVID, exposure to COVID, including from employment, essential workers, healthcare workers, grocery employees of food processing plants, also qualify for testing. Next slide, please. So currently, Public Health Ontario is doing a real-time PCR for the E gene, which is the envelope gene over here, Roche has its own test kit, which is the open reading frame gene. Abbott uses their RNA-dependent RNA polymerase gene as well as the N gene. So the PHO is currently using the E gene in real-time PCR assay. It's more sensitive than the other two targets, and a single target is reported as positive. If there's no gene detected, then it's negative. Intermediate tests, then they use either the Roche Abbott or they send to the Winnipeg lab for confirmatory testing. Next slide, please. The question is, how good are these tests? We really don't have a good answer for that. In China, at least, the thought was that sensitivity of this test is anywhere from 50 to 80%. This was an interesting study that combined a few trials to see what really the false negative rates were. So it was looking at variation in false negative rates of reverse transcriptase polymerase chain reaction based on time since exposure. So you get some interesting findings. You find that on the day of infection, when you first get the symptoms, you probably have a false negative rate of 38%. By day 3, you have the lowest false negative rate, which is around 20%. But these are not good numbers, especially in the pre-symptomatic phase, where the false negativity rates are very high. And then basically after 3 days of symptoms where, would you mind going to the previous slide? Where the false negativity rates start to rise up again. So at its best, it seems the best time to do a test is day 3 or so after symptom onset. Next slide, please. So based on this, they calculated, the pre-test and post-test probability. And really, if your pre-test probability is very high for the diseases here, a negative test really does not rule it out. It's good if you have like a very low pre-test probability, then you can rule it out. All to say that a negative test does not rule out COVID-19 in people with a moderate to high pretest probability. So at least at the Queen's of Carleton, what we're doing is if there's a high pretest probability, we repeat a test, and we try to get low respiratory samples test. So if possible, get a bronchoscopy, and if that's still negative and suspicion is still high, then we just leave them on drop-in contact precautions and presume that it's COVID-19. Thus far, the turnaround time for us in Ottawa is around 24 hours for the testing. Next slide, please. Okay, so potential treatment options. Next slide. I'm going to list a bunch of treatment options and some evidence for them, but this is all to say that we don't really have good treatment options. It's supportive treatment with oxygen, if they are intravascularly dry, fluid rehydration, if they have co-infections, treating the co-infections, if they need ventilator support. There's numerous trials ongoing, and hopefully they'll shed some light. So one of the biggest things was hydroxychloroquine, which is typically used for lupus, malaria, and rheumatoid arthritis. And there were 3 possible mechanisms that were proposed for it. One was interference with ACE2 receptors, which is what the virus uses to bind, impairment of the acidification of endosomes, immunosuppressive properties. And there was some in vitro data to suggest that chloroquine inhibits COVID-19 infected cell lines. Next slide, please. There are a lot of problems with hydroxychloroquine. The biggest one acutely is QT prolongation. Everything else is kind of long-term usage. Next slide, please. There have been a lot of smaller studies done, but this is the largest that I could find, and that's why I wanted to highlight this one. So this was hydroxychloroquine or chloroquine with or without macrolide for treatment of COVID in a multinational registry analysis. It was 671 hospitals in 6 continents from December to April. Total of more than 14,000 people. And they received chloroquine plus a macrolide, hydroxychloroquine plus macrolide. And what's interesting is there was no difference in mortality. But there was definitely a difference in arrhythmia. So more people had arrhythmias when they were using chloroquine or hydroxychloroquine. Which leads me to believe as of this point, we should definitely not be using hydroxychloroquine unless it's part of a clinical trial. But I think so far the evidence does not point towards effectiveness. Next slide, please. The second agent that was trialed was Kaletra or lopinavir ritonavir, which is an old school HIV agent. Most of this data comes from SARS and MERS coronavirus, suggesting that it works synergistically with ribavirin. It does have a lot of adverse effects. Practically the most adverse side effect is multiple drug interactions that it has. Next slide, please. So this study was published in the New England Journal of Medicine. It was a randomized controlled open label trial, and they enrolled people with O2 saturation of less than 94%. And they were randomly assigned to Kaletra with the standard treatment, and there were 199 people totally, and there was really no difference in mortality. So I think with this study, we've kind of, I mean, at least right now, Kaletra is kind of off, it's probably off the treatment modalities. Next slide, please. Remdesivir is an exciting agent. It interferes with the action of viral RNA polymerase. It was actually developed initially for the treatment of Ebola, but then later repurposed to find that it works against COVID-19. And initially all the trials were being done by Gilead, who was offering for compassionate use, but now it's only been offered as part of study trial. Next slide, please. So this article is hot off the press. It was just published on May 22nd. It's the largest remdesivir trial. It was a double-blind, randomized, placebo-controlled trial, and people were given IV remdesivir, and they were hospitalized. Randomly assigned to remdesivir for 10 days versus placebo, and the primary outcome was time to recovery. There were a total of 159 patients. So what's interesting is that overall the time to recovery was statistically significant, where 11 versus 15 days. But then once you look deeper in the data, what's interesting is that people who were intubated or on ECMO, there was no statistically significant time to difference in recovery. And people who were having no oxygen had no statistical difference. It was only people who were requiring oxygen but not super sick. So I mean, the limitations of the study in the sense that it was some populations were underpowered, but there is a signal there, but it seems as a very narrow signal in just people who are sick but not super sick but not too healthy. Like it didn't seem to make a difference in intubated people. It didn't seem to make a difference in terms of length of stay in people who require no oxygen. Only those people who required oxygen. It seems like a very narrow scope of this drug. That being said, that particular population was underpowered, the intubated people and the people who were not requiring oxygen. There was no statistical significant difference in terms of mortality. So the question is, does this kind of take the, there's a signal there, but I think we still need more studies and more information on this. Next slide, please. One of the agents that is also attracting attention is tocilizumab, which is a recombinant human monoclonal antibody that binds to IL-6. IL-6 is a cytokine that was responsible for the cytokine storm that you kind of get that leads to ARDS. There have been multiple small studies published, and there's some signal there, but really larger randomized control trials are underway to hopefully guide us in the future. Next slide, please. And the last treatment modality that has been explored is convalescent plasma. The thought is that I get COVID, I have immunity, I have a set cutoff of antibody or IgG, which is above an X point. I donate plasma. Somebody who's sick gets that plasma and they get better. So far, there's only been case series. 5 critically ill patients in ARDS in Shenzhen, Canada. All 5 received convalescent plasma. And there was ARDS resolution in 4 to 5 patients. Again, very small study, but maybe there's something there. So next slide, please. So really, treatment is supportive. There's no good treatment modality that's available. Remdesivir is promising, but needs more data. At QCH, we're participating in the CAPCO trial, which is part of the Solidarity arm of the WHO trial. That's looking at hydroxychloroquine. It's a randomized open-label study looking at hydroxychloroquine, remdesivir, and Kaletra versus placebo, and then also Concord. One trial, which is looking at convalescent plasma and its utility. So hopefully we can get some more data from it. But I think that's all I have for you guys. Any questions?
Hi, I can't see the chat box. I'm just wondering if we'll stop sharing the screen.
Sure, I can maybe read you, Sunil. There's one question. What is the false negative with second test?
Don't know. Don't know. The thought is, yeah, we don't know. What's the false negative for second test? The thought is that, okay, if you test it very early on in the disease and it's negative, then you're testing at day 3, 4, then probably there's more likelihood that the disease will be the test will be positive. But if you're testing, say, beyond that time period, we don't know what the false negative rate is at that point.
Great. Okay, I can see the questions now. Another question. Given the thrombosis, Given the thrombosis associated with COVID-19, is there any benefit in starting anticoagulation on someone who has symptoms and a hypercoagulable condition? Greg or Karin, any takers on that?
I know there have been, so I don't know particularly about someone who has a hypercoagulable condition, but I do know that there are some institutions who are, normally we use low molecular weight heparin at 5,000 units once a day, but some institutions are actually doubling up that dose just because of that, especially if the D-dimer is very elevated. The study is actually ongoing to see if that is beneficial or not. Unfortunately, I'm not sure when it comes to particular anticoagulation, this particular prothrombotic condition, what the right answer is.
Maybe I'll take one more question now because some of these other questions will cross over into Greg's talk. Dr. Chandrasena is asking about immunity after COVID. Is there a quick synopsis or a quick take-home message about that?
I can take that if you like. Unfortunately, Chandy, this hasn't really changed a whole lot since I first started talking about this in March. And in a nutshell, what we know about the immunity of humans against coronavirus largely comes from the 4 strains of human coronavirus that cause rhinitis. Those tend to circulate every couple of years with minimal genetic change. And one of the reasons for that is neutralizing immunity, at least humoral neutralizing immunity to coronavirus is based on antibodies against the spike protein. And that tends to wane over a couple of years, as does T lymphocyte cell-mediated immunity. So the vast majority of our experience with coronaviruses in humans over 5 decades now is that every couple of years, pretty much exactly the same 4 strains of coronavirus circulate again and again and again. Now, with the numbers that Dr. Sharma presented, you'll see that the numbers of people who've been infected with more serious coronaviruses are actually very small, a little over 10,000 total with the combination of SARS and MERS-CoV, none of whom were ever re-exposed to those coronaviruses. So we don't know if those have some different way of triggering immune response. It is theoretically possible because these affect the lower respiratory tract, and you have a different kind of milieu. You've got macrophages in the alveoli, which are more likely to lead to antigen processing and more likely to lead to T lymphocyte cell-mediated immunity. You may have a more robust long-term immune response. Simply don't know. What I often like to quote as a, shall we say, a sobering reflection. Our only experience with developing vaccines against coronaviruses that have actually been put in use are vaccines for cats for a coronavirus-mediated disease called feline infectious peritonitis. And the story is not encouraging. Inactivated virus vaccines, so vaccines based around the spike protein of the coronaviruses, actually worsen the disease that cats subsequently develop if they're exposed to wild-type virus. And so those were abandoned after many attempts at developing a successful vaccine. Eventually, a live attenuated virus vaccine was created, which did not hasten the cat's demise, but it is almost never used because it actually has very little benefit in terms of preventing this infection. And it is very concerning for vaccinology that this suggests that vaccines might not be possible. I don't have slides about this, but there may be some rays of light in terms of new ways of attempting to elicit immunity. But it also suggests that long-term immunity to coronaviruses might not be possible. Truth of the matter is, we don't know. We haven't had long-term yet with these significant numbers of people developing this much more severe infection. The absolute best case scenario is you have lifelong immunity to COVID once you've had infection. A definite thing, I believe, is that you do have at least partial complete immunity if you've recovered from COVID. Yes, there have been people who have had detectable viral RNA in various swabs for weeks up to 35 days after symptom onset in some cases, but they're not necessarily sick, and I suspect what you're seeing there is shedding of basically fragmented virus, as Dr. Sharma has suggested, rather than people becoming reinfected. The worst case scenario is that there is no immunity for any of us, or there is no long-term 100% immunity, and the same SARS-CoV-2 more or less comes around every couple of years and kills off a larger and larger percentage of the population until either humanity is extinct or the world explodes, or global warming gets us. A realistic and I think intriguing possibility is that having survived proper COVID-19, so that's the disease entity caused by SARS-CoV-2, perhaps we will have enough partial immunity that the next time the virus decides to circulate the globe in 2023 or 2024, it will basically only be able to cause mild upper respiratory tract symptoms, which might suggest evolutionarily that the four circulating human coronaviruses that we know about might have started life as a more significant syndrome as well.
Thanks, Greg. There's a few more questions, but I'm going to save them because they do cross over to infection control. And on that note, I'm going to turn it over to Dr. Greg Rose, who's, as mentioned, a friend and colleague here at the Queensland ID consultant and also the chair of our Infection Prevention and Control Committee. Greg, I have your slides. I don't know if your slides, if you want to just control them yourself.
I'd rather control them myself, so do you, of course my network has decided to clap out. Do you see them?
We do, yeah.
Excellent. Tell me if you can't after a while, because I've just gotten a warning that my network has decided to become unstable. My son is probably playing some kind of violent game on the computer, I should add. There we go. Okay. So yes, curmudgeonly IPAC potpourri, I being the curmudgeonly IPAC doc. Essentially, over the course of the next several slides, I would like to address three questions that are recurrently brought up to me or brought up in social media contexts, which inform the current IPAC milieu when it comes to COVID. Now, I know Dr. Sharma actually gave you a very detailed discussion of transmission, but I want to talk about this apparent controversy around airborne transmission as well. And just as a way of verbiage first, airborne and aerosol are completely synonymous terms when we're talking about this mechanism of disease transmission. Droplet nuclei are a more or less synonymous term as well. Droplet nuclei are droplets, so large respiratory particles which evaporate in the air until they shrink down to the point that they're the same size as essentially an aerosolized particle. So as Dr. Sharma has already described, we believe this disease is almost entirely transmitted by droplet in contact, but this question of airborne spread has come up again and again. And where has that come up from? So there have been a number of lab-based studies, mostly based on PCR, although some of them have been based on viral culture, which suggests that airborne might be a significant route of transmission. I'm not going to go into details of all of these. The first one on these, actually, Dr. Sharma showed you a graphic from this. This is the survival of virus. If you take a industrial strength Collison nebulizer and pummel the virus into an aerosol and then put it in a special box designed to maintain things in aerosol, when you do that, you find that you've maintained it in aerosol, which is more or less exactly what those machines are designed to do. Not necessarily that clinically significant. There are, however, a number of environmental studies where viral particles have been demonstrated in circulating air currents more than 2 feet away from infected patients. And the question has become, does this mean that we are going to see transmission of this virus in an aerosolized based setting? One of the most leading of these all was published by researchers at the University of Nebraska, Santarpia et al. This has actually not yet been peer reviewed and published. This has existed in a pre-publication form for the last 2 months, which, given the speed at which the literature is developing, I'm not quite sure what the peer review conversation has been about that article, but that one was extremely popular because this demonstrated that, you know, outside patient rooms and down the hall, they were detecting virus in the air. There are some empiric evidence studies which have been essentially agnostic. The first major outbreak in the United States, or one of the first major outbreaks reported in the United States, published in Morbidity and Mortality Weekly Reports, showed evidence of healthcare worker acquisition of virus more than a couple of feet away from infected patients, but there wasn't any PPE in use in this particular outbreak. So it's really hard to say whether actions that would be put in place to control aerosolized or airborne spread would have been more effective here than droplet-based spread. What we do have, on the other hand, is a number of investigations, empiric shoe leather epidemiology investigations, shoe leather epidemiology being the term that we use as epidemiologists to sound cool. We kind of think of ourselves as detectives. Examining the nature of spread of this infection in a variety of outbreaks. And the first reference on this list is actually the WHO systems report into the initial outbreak in Wuhan. 78,000 patients, a fairly detailed epidemiologic investigation during which they could not identify a single episode of airborne or aerosol spread of the infection. There have been a number of other smaller exposure events, and these are all basically case series that are listed here, where, for example, patients are being intubated and multiple healthcare workers are being exposed in the absence of N95 or KN95 as the standard is in Asia, or FFP2 as the standard is in Europe, respirators, and still did not get sick, suggesting that droplet-based precautions in these particular outbreak investigations were sufficient to protect the healthcare workers. There's a number of other reasons to believe that airborne spread is not a significant cause of transmission of this infection. Probably one of the most close to home is that when we look at our own outbreaks, and there have unfortunately been several in the hospitals here in Ontario, we are not seeing widespread geographic spread of these infections. Geographic meaning, you know, down the hall and around the corner, the way one would expect with an airborne-based, a truly airborne-based pathogen such as measles or tuberculosis. We're seeing these things happening in very close contact, often with fairly prolonged contact, which is what we would expect to see with a droplet over the contact-based spread. One of the issues, though, that I'm often accused of, and other infection control docs are often accused of as well, is that we oversimplify and we over-dichotomize the message that we're trying to get across. So this is the finest Microsoft clip art that I could generate for you, and I hope you will bear with me. But the perception that we've unfortunately left our colleagues with is that there's two completely separate classes of nasty wet things that come out of your mouth when you speak or cough or breathe. There are aerosol or airborne or droplet nuclei, little tiny respiratory particles, and then there's big droplets, big being a relative term. And furthermore, that we seem to be suggesting that those aerosol-based particles do not have virus on them, whereas the droplets do have virus on them, as if the virus was somehow choosing what size of bit of fluid it's going to hitch a ride on as it exits your mouth. Furthermore, we've made it seem like it's so very dichotomous that, for one thing, when an aerosol leaves your mouth, there's no viruses in it, and it goes, as aerosols do, to circulate in all directions around you, following air currents and capable of traveling many meters, where droplets follow a perfect arc exactly 6 feet out from your mouth and hit either the ground or surfaces. For simplicity's sake, this is the way we teach it. However, of course, as with everything, real life is much more messy. In point of fact, some of those little droplet nuclei will have viral particles. And in fact, some of the larger droplets will not have particles. There might be small amounts of virus in aerosol coming out of a person's mouth, as some of these studies have suggested. And furthermore, when droplets do come out of your mouth, rather than traveling exactly 6 feet and stopping, they actually have a stochastic spread over approximately 6 feet. So this was actually, unfortunately, meant to be a bell curve, where we're getting out to the 99th percentile tail by the time we hit 6 feet. So that it is actually possible for small amounts of droplets to make it beyond that point. And in fact, some very famous outbreaks that have occurred in the context of this pandemic have been longer than 6 feet. And two of the ones that I am personally most interested in are the famous choir in, I believe it was New York State, where over the course of singing in a fairly small confined, but 20-foot wide room, multiple members of a chorus became infected by one member who would have been considered a super spreader. amongst other things, it suggested that singing and projecting, you're actually not just projecting your voice, as anyone who's had musical training tries to do, but also you're projecting your droplets. In fact, one of the reasons I'm outside right now is I'm only projecting my droplets on my picnic table rather than on my family, because I am speaking rather loudly. And of course, there's also the outbreak amongst a bonspiel of physicians in Saskatchewan, where again, perhaps too much shouting of hurry, hurry hard by an infected physician actually spread the droplets a little bit further than just 6 feet. So this is not completely black and white. It's not definitely this is aerosol, definitely this is droplet, not aerosol. It's only 6 feet, that's the end of the story. We're talking about what is the most highly probable state of transmission. And the things that we do in infection control to mitigate that are all based around what is the most probable thing that we can reasonably address. This is where we start to get into some of the push and pull of what is actually feasible in the context of a global pandemic, where PPE supplies are in short supply globally, where airborne rooms capable of keeping patients on negative pressure are in short supply, where timelines and patient movement in hospital are major sticking points, because if you admit a patient to, for example, a regular room on droplet contact and then you think they have COVID, you have to move them into a negative pressure room. Had we had a perfect world scenario where we had complete ability to maintain every single patient in hospital on airborne precautions in addition to droplet contact, and we were able to supply enough N95 masks to every single healthcare worker in hospital, I'll be honest with you, we still wouldn't have done that once we started accumulating that empiric data that I've already alluded to. And the reason for that is it's bad science. There are drawbacks to the N95, including dermatitis around your mouth, as many of you who have worn N95 respirators will note, as well as excess costs, as well as increased isolation for patients and poor outcomes from being in isolation. I beg your pardon, it's starting to rain. I'm going to move an electronic device here. One moment. That was more or less the best way of guaranteeing rain for my garden, was working out here today. So when we look at mitigation, we try and base our decisions not just on the science, but also on what is feasible and what is, in the end, best balance between safety to patient, safety to healthcare worker, as well as addressing the adverse effects of the measures that are put in place. It's been well demonstrated, for example, that being in single room isolation for any reason, droplet contact, for example, due to VRE or MRSA or diarrhea, and certainly airborne, means your healthcare workers see you less often, you get worse care, your meds are more poorly timed, you're more likely to develop bed sores, you're more likely to actually, if you have a pre-existing cognitive issue, you're more likely to develop delirium from lack of stimulation. Mood disorders tend to get worse. So all of these things become part of the calculus. So the takeaway here is that really droplet contact is the only well-described route of transmission for this particular infection. However, aerosol may be possible when certain variables are pushed to their extremes. This has not been proven in empiric data. However, the density of aerosol product, again, singing, shouting, coughing, these things might increase aerosol products. Certainly aerosol generating procedures such as intubation or placing a person on nebulized medications, these are thought to increase the density of small particles with virus in them. Poor ventilation. I'd mentioned earlier that study in the New England Journal, they used something called a Collison nebulizer to create an aerosol, and then they used a special box to maintain those aerosols. Poorly ventilated rooms function like that specially created box to maintain aerosols. And this is really interesting. One epidemiologic investigation in a hospital in Wuhan did another one of these studies where they basically go around and they take PCR samples from a variety of environmental sites. Surfaces around the patient, those are always the highest in terms of amount of viral RNA. Basically anywhere within 3 to 6 feet of the patient, surfaces are going to be completely loaded with virus. But in terms of their air quality samples, the only parts of the hospital where they found really elevated amounts of PCR were in the employee change rooms. And the reason why is these were essentially airless boxes that people would go into wearing. You'll probably have seen in the news back in March, they were wearing these white head-to-toe suits made out of Tyvek, the same stuff that we use as vapor barrier on houses. Tyvek, being a plastic surface, is very good, as we've already seen from environmental survival data, it's very good at maintaining viability of the virus over a long period of time. And it's electrostatically charged, meaning if you shake it, virus flies off of it. So when you're taking this Tyvek suit off, you are showering the environment around you with virus, and then it's happening in a tiny little room with very little airflow, certainly no major air exchanges, and then somebody else is coming in shortly afterwards to get changed. So actually, it's believed that this particular change room was one of the major vectors, or sites rather, for transmission of coronavirus to the healthcare workers at that hospital. And I suspect, having had visits to a number of the long-term care facilities around Ottawa in the context of their outbreaks, I suspect the change rooms supplied to healthcare workers in other sites around Ottawa may similarly be subpar in terms of ventilation. And finally, the duration of exposure. This one we don't have great data in terms of SARS-CoV-2, but we have great data from a variety of other respiratory viruses. The longer you spend within that 6-foot circle, the much more likely you are to get a significant enough amount of virus into your respiratory tract that you will become ill. This is the infectious dose, and I can't give you a number as to what the infectious dose is. We don't have that, but we do know that the longer length of time you spend near a person shedding virus, the much more likely you are to acquire it. And this becomes important in a couple of spheres. One of the questions that I've been asked recently is, when the weather's nice, people are out and running on the bike paths. If I run past a jogger breathing hard who's breathing out coronavirus, am I going to get it? Chances are no. You have to spend at least a few minutes in their airspace. A single breath taken within a 6-foot radius of a person is unlikely to transmit this to you. Again, Dr. Sharma had presented data from the restaurant in China where several people had become ill from a diner at the middle table. This was a 40 to 50 minute exposure in fairly close proximity to that diner. And even there, it wasn't 100% uptake of the virus. Dr. Sharma had alluded to fecal-oral transmission. We have detected viral RNA in stool, we have detected in intestinal cells, and we've detected in sewage effluent. So, theoretically possible that you might be able to pick this up from fecal-oral transmission. Boy, oh boy, what do we do about that? What do we do about anything in infection control? We wash our hands. Fecal-oral transmission is only a route of transmission if you don't interrupt that acquisition on your hands getting into your mouth. So good hand hygiene is absolutely the core to addressing these unknown but plausibles. Vertical transmission, mother to baby, this one has been a bit more controversial. Certainly the early data did not suggest that vertical transmission was a major factor. There have been a couple of cases where it seems like it might plausibly have been a factor, but it's not, unfortunately, definite. And then there's a couple of transmission routes, such as bloodborne or vector-borne, which really don't appear very likely at all. So the next thing that grinds my gears as an infection doctor, is a question I always get asked about. Is it time to stop doing everything that we're doing? The lockdown, the economic harm, the social distancing, the quarantine. I know from many of my friends who are physicians in this city, their Facebook feeds are full of jokes about how bored they are sitting at home all day baking desserts and drinking. And as an infectious disease and infection control doctor over the last 2 months, I have to say it sounds idyllic to me, but I do get where you're coming from. So there have been opinion pieces, particularly this week. There's been some hard-hitting opinion pieces, one of which was actually filed by some infectious disease colleagues of mine in the GTA, as well as a less, frankly, evidence-based but slightly more inflammatory one from a mathematician who believes he understands epidemiology better from his 2-month exposure than most epidemiologists do. which urge lifting social distancing. The Swedish model is often touted as a better way of going about things, ignoring the mortality associated with the Swedish model. I'm really not going to get into that unless you really want me to. Popular protests against social distancing are gaining steam, not just in the States, where yahoos are showing up with automatic rifles on state legislatures, but here in Ontario as well. And just this weekend, of course, we had very large, very crowded protests in Trinity Bell Woods against social distancing. People are getting sick of being at home. People are getting sick of the economic pain as well, and it's absolutely true. There are definitely economic consequences. As physicians, I'm not sure how many are online right now, but we definitely know some of our colleagues are not going to be reopening their practices at the end of all this. In fact, a fairly large family health team in Orleans has already declared its intention to shutter its practice, and there are several others that are threatening to do the same. There are health consequences. Patients have been staying away from the emergency. Again, they have it in mind that this is SARS and that they're going to get COVID at the hospital. In point of fact, you are far more likely to get COVID outside of the hospital than you are in the hospital. And there have been unfortunate consequences. We are just starting to see that particular tide turning as emergency room visit numbers for non-COVID related reasons are rising across the Ottawa area over the last week and a half after basically a 7-month dry spell. But there are definitely consequences to the social distancing. So is it over yet? I'm going to show you some stuff, but first I want to talk some basic epidemiologic terms. Growth curves. So this is a curve for exponential growth where basically patient numbers double every day. And you start off relatively flat, but once you start steepening, it goes steeper and steeper and steeper and steeper and steeper until eventually, you know, if this went out to infinity, you have had a completely vertical curve of new patient, total new patients, so cumulative incidence over time. Slightly more realistic version of the same graph is with a Fibonacci sequence. Fibonacci sequence famously being the golden number where, you know, 1, 2, 3, 5, etc., etc. Again, though, over time, this would eventually trend towards being a completely vertical line. So exponential growth, of course, is completely uncontrolled infection, which is rapidly spreading from 1 person to 2 people to 4 people, etc., etc. There is arithmetic growth, and arithmetic growth means you get the exact same number of new cases one day after another. This particular example is one new case new case per day. So day 1 we have 1 patient, day 2 we have 2 patients, etc., etc. With arithmetic growth, you get a completely flat line. Now the slope varies. If you get 3 new patients a day, it's a steeper slope. If you get, you know, a new patient every couple of days, it's a more shallow slope, but it's a straight slope. And finally, there's logarithmic growth, which is a good thing. Logarithmic growth means you're getting fewer new patients every single day, and that is what we talk about when we talk about flattening the curve. So the curve of cumulative incidence eventually becomes a flat line. Okay, bearing this in mind, here's the global picture. I'm going to go through global, national, and local pictures and a little bit of provincial as well. 10 minutes. Yes, I probably can wrap it up in 10 minutes. So ignore the number in the top left corner. 6 million is a scary number. This is the graph of global incidence, cumulative incidence since the start of the pandemic. It has essentially been in an arithmetic growth phase since early April, and it shows no signs of changing. This is our national cumulative incidence. Follow the links. We'll get you the slides if you want them. This is a really cool map. When you roll over a number, you get a different graph here in the corner depending on which jurisdiction you're looking at. Canada was largely arithmetic growth up until the last couple of weeks when it changed curve a little bit, and then seems to be an arithmetic growth at a slightly shallower curve. So there's a bit of flattening there, but it's not a sustained thing. Let's look province by province. Who's doing well? Well, New Brunswick generally is doing well. They flattened their curve in early April and they've remained very flat since. New Brunswick was actually in the news today because a healthcare worker in Campbellton visited Quebec, picked up coronavirus, came back, treated something like 150 patients over a 2-week span, 3 of whom became ill. So the medical officer of health is quite upset with that physician. I tell you, 3 new patients in a day would be quite a good thing compared to Ontario numbers. So they've been flat for some time. Manitoba's been flat for some time. Saskatchewan flattened. Then they became exponential again because they backed off too quickly on their social distancing measures, and then they tightened up again and they flattened. BC flattened. BC was actually more of an issue of testing and a really good public health outbreak investigation rather than social distancing. They have been doing social distancing relatively well in BC. That's kind of fallen apart in the last few weeks, and they haven't paid any consequences yet. It'll be very interesting to see what happens, though. Ontario and Quebec, unfortunately, seem to be on more or less linear arithmetic growth curves, and they haven't changed a whole heck of a lot. That's province-wide. Locally, it's a little bit more of a rosy picture. The first wave, as we often refer to it, of community-acquired cases actually started in March and was more or less over by early April. It's been tailing off since then. The problem in Ottawa, as frankly the problem across much of Canada, has been what's been happening in long-term care facilities, which became particularly a problem in late April, with intensive intervention, including having hospital staff and hospital infection control personnel going into some of the hardest hit nursing homes here in Ottawa. We have managed to improve that home by home. Some of them actually have it under control. Some of them are still struggling a little bit, but there's definitely been an improvement. And if you look at our local cumulative incidence curve, it's flattening. In fact, an opinion piece would have it that over 90% of more recent new COVID cases are occurring only in the Greater Toronto area. Ottawa and other parts of the province are doing very well by comparison. However, this is just the tip of the iceberg, what we can actually see in terms of confirmed cases. We don't really know how many unknown cases there are compared to known cases, but one estimate from a seroprevalence study taken in Santa Clara, California at the start of the California outbreak had it that there was about 54 unknown cases for every one known. So let's 53 for every one known. So let's take that number and use it on Canadian data. We have had confirmed 87,902 cases in Canada. So if we multiply that by 54, possibly we might have had as many as 4,746,000 people acquire COVID, which seems like a big number, especially when we're talking about 6 million confirmed cases worldwide. When you look at that as a percentage of the population, though, it's about 12% at the outside. Herd immunity, well, we don't really know where herd immunity starts for this virus, but unlikely that it starts any lower than about 70%, which would be here. We have a huge gap to surmount before this is even presuming, by the way, that there is long-term immunity to this infection, but there is a huge gap we have to surmount in order to actually get to the point where we can really relax and be certain that we're not going to have sustained spread in our communities. We're just not there yet. The WHO has 6 criteria that they put in place to lift restrictions. One is that disease transmission is under control. And in Ontario, that's not necessarily the case, particularly in Toronto. Another is that health systems are able to detect, test, isolate, and treat every case and trace every contact, which assumes that both the hospital system and the public health system have the capacity to deal with the numbers. And I can tell you on both of those fronts, we probably don't. 3 is that hotspot risks, particularly nursing homes, are minimized. We are just starting to get to that point now in Ottawa, and it's not at that point yet in other parts of the country. Schools and workplaces have established preventive measures. They might have preventive measures. I know Quebec went back to school 2 weeks ago with preventive measures in place, and they hadn't even got to the end of the first week before a child showed up with symptomatic COVID and exposed a number of other students. Risk of importing new cases can be managed. That basically is referring to border controls. And finally, communities are fully educated, engaged, and empowered. I would argue that our communities are not necessarily fully educated and engaged. This is Kitsilano Beach 2 weeks ago in Vancouver. I would hazard that most of these people are not really maintaining a 2-meter separation, and none of them are wearing masks. So this is definitely the kind of thing that can lead to a problem. We're worried about the second wave. We saw it with Spanish flu. This is just the British curve. Essentially, around July of 1918, they decided they had had enough of social distancing measures and they backed off, and they had a huge spike into the fall. In fact, more people died of Spanish flu than died of World War I. We've actually kind of already seen a second wave briefly and abortively start in Ontario. These are provincial data. This spike here more or less corresponds to the incubation period out from Mother's Day, when people, including the Premier's own children, showed up at homes of their mothers to visit them when they should have remained at home in social isolation. So every time we back off, the numbers do creep up. That is very clear. Modeling suggests that if our efficacy of social distancing in Ottawa diminishes by 20%, we will have a second wave start into the summer and spike sometime in the fall with cases. The median projection would suggest early September being the spike. Now, this is a static projection. This is if social distancing falls apart by 20% and stays that way. If it fell apart by 20% and then we tighten it up again, basically you'd see these little undulating hiccups in disease number. But certainly the efficacy of social distancing appears to be critical. And there's a number of influencing factors. I'm going to skip over that, but the takeaway from this, and I apologize, I know Churchill can be a divisive figure, but this is a lovely quote. Now is not the end. It is not even the beginning of the end, but it is perhaps the end of the beginning, the end of the first wave. I had one last thing I wanted to talk about. Do I have time, Dr. Varghese? I've got about three slides on this.
We have about 10 questions to answer on the side. I just want to give some time to talk about those.
Sure. The Ministry of Health has specified that it wants 16,000 PCR or tests to be done on a daily basis in Ontario. They are doing this partially because they've been encouraged by prominent epidemiologists that test is how you find out what your numbers are. It gives you an idea of the scope and the shape of the disease outbreak in your population, and this is more or less true. I don't know exactly how the number 16,000 was got to. However, there has been grave disappointment voiced by the Premier and the Minister of Health in the lay press over the last few weeks that we have not reached this 16,000 threshold. So just this weekend, the Premier announced that anyone who wants a swab, who feels that they've been exposed to COVID, or who works a job where they think they might have been exposed to COVID, can come in and get tested even if they don't have symptoms. This was a bit of a misleading statement by the Premier, because amongst other things, he told people that they don't need appointments. They can just show up at COVID assessment centers, and that is not true, depending on the COVID assessment center. It is true in Ottawa, but it is not true in many other jurisdictions in Ontario, just because the resources are so limited. And in addition to this, the Premier's office has been calling some Greater Toronto Area hospitals, telling them essentially to test all their healthcare workers, to basically appoint prevalence across the organization, which is a source of great stress to some of my infection control colleagues in the GTA. So where did that take us? Well, that announcement was made on Saturday. By Monday morning, our emerge numbers at the Queensway spiked. Across the city, day-to-day case testing numbers have tripled at the Brewer COVID Assessment Center and at the West and East COVID Care Centers. Below this, you'll see the graph province-wide of test numbers in the blue bars versus the percentage of tests that are positive. And it's very clear, the more tests we're doing, the less likely we are to be positive. And in fact, with this increase in testing people basically just showing up saying, I would like to be tested because I think I should be, the numbers have started to drop again. This is about 4%. In fact, locally, I can tell you it's closer to a 2% positivity, and that's before the change in those criteria. This is not a benign policy. We're talking about severely limited resources. The test kits are still in short supply. The swabs themselves, those breakaway mini-tip swabs that are put in the nose and mouth, are in short supply. The transport medium used to actually get those to lab are in short supply, so we've been needing to use alternatives such as plain normal saline. This is labor intensive. This is time intensive. If patients are coming into hospital or they require surgery, for example, and they've been tested for this reason, and we have to put them on precautions because they've been tested, and that's what we do. If you need testing, if you have a high enough likelihood that you think you need testing, well, then we need to isolate you. This uses up scarce isolation beds. It uses up PPE. So this kind of a shotgun approach is quite intensive in resources. Now, if that actually had a benefit, it would be worth doing. But I believe that testing should be a bit more purposeful than simply show up if you feel you'd like to. Testing should be done ideally to find patients who need therapy, although therapy right now is supportive. It should be done to identify patients of epidemiologic importance, and this was largely the focus of testing for the better part of a month and a half, looking at healthcare workers, for example, and the very ill, and people living in conjugate living settings like long-term care facilities and jails and the like. Or if you're going to throw it open to the general population, do it in such a fashion that you can use that to get a good estimate of what your disease prevalence on a day-to-day basis is, as well as what your disease incidence is. And to do that, really, you need to identify a sampling frame, and you need to take a random sample rather than just throwing it open and saying to people, come in if you think you want to. So there are ways of doing what the Premier wants us to do, but it should be done in a more intelligent fashion that gives value added to the entire system as a whole. And that's going to take some thought. And I'm going to tell you now, this is going to vary on a location by location basis. The folks in the Greater Toronto area have a direct degree of pressure being applied on them to do such testing. And while there is going to be a conversation, I think they're going to be obliged to follow through with this. In Ottawa, even though we do have that statement from Ottawa Public Health, essentially urging us to go ahead and test as the Premier has decreed. The medical systems in Ottawa, who work under an umbrella called the Champlain Health Regional Incident Command, are going to take a somewhat more nuanced approach while we look at things such as developing a sampling frame and doing random testing in order to, a random sampling rather, in order to get a better idea of what the actual shape of the epidemiology is in Ottawa. There'll be more on that, I think, in the next week or so. At this point, I'm going to take some questions, or I guess we already have questions. I suppose I should stop sharing my slides.
All right, thank you very much, Greg. Thank you very much, Karin. There's about 10 questions there. If you have questions, please put them in the chat box. I'm going to try and lump them a little bit. And one area is the actual infection control in the hospital. So I'm not sure how many people are actually online right now and how many hospitals they come from or what community settings they come from. But there's a bit of controversy in terms of what infection control procedures are required for certain procedures. The big one being Code Blue. What is the role of N95s? What is the role of negative pressure rooms in these aerosol generating procedures? I'm wondering, Greg, if you can just take a couple minutes to talk and address some of those controversies and some high level evidence supporting what we do here at the Queensway, and I think what a lot of other institutions are doing as well.
So it boils down to that statement that I made, that while we only know for a fact that droplet and contact are routes of transmission, aerosol is theoretically possible. Now, interestingly, there have been codes that have been run without droplet contact precautions. There was one in Singapore. That's one of the references in an earlier slide of mine, where none of the healthcare workers acquired COVID. So it might be overkill to have an N95 in place when you're running a code on a person who's got COVID. But out of an abundance of caution, we are doing protected Code Blues. Similarly, for aspects of surgery that would involve manipulating the upper airway, we do airborne precautions. So N95 mask in place. For intubations, the intubation is occurring in a negative pressure room. For certain types of surgeries, however, well, surgeries in general, ORs are not run on negative pressure. ORs are always on positive pressure to blow particulate matter out of the OR, with the thought that that's going to diminish the likelihood of a surgical site infection for the patient. And for safety reasons, and also frankly for engineering reasons, we cannot alter that. So we are using N95 masks, or N95 respirators rather, in ENT procedures, but they're being performed in positive pressure rooms. As I say, the evidence behind it is essentially nil. There have been no demonstrated transmission events from these kinds of procedures. The closest thing to it, and this is a study, this is an incident that has been very badly distorted over several iterations. if there are any ENT doctors currently on the seminar, they will probably have heard from their ENT groups. I beg your pardon, it is now raining rather more heavily. I've got to back up from it. They will have been told that there was an ENT doctor in China who died of COVID early in the course of the pandemic. I've actually followed the trail of opinion pieces talking about this incident back to the actual report that they're referring to, which is written in Chinese, but I used Google Translate to work through it. It's a lay press publication rather than an actual scientific publication. And it's actually quite interesting because, in fact, what it was a person who underwent not an ENT surgery, but a base of skull neurosurgery. And then about a week and a half later, several people in his hospital became ill, with several healthcare workers in the hospital became ill with COVID. The really interesting part about that is this was clearly some kind of political bun fight between the hospital and the local government. In fact, the government had made one claim about poor practices being applied and stated that it was several operating, like 14 operating room nurses and a surgeon, whereas the hospital itself, stated that it was a gynecologist, a gastroenterologist, and 2 neurologists, none of whom really had anything to do with the neurosurgery itself. So there really is no clear evidence that there's been transmission in that setting. You'll also have heard probably that dentists and ophthalmologists and anyone else who works at the head of the patient are at higher risk because of close proximity to the mouth. And while that might be putatively true, it has not been demonstrated.
So thank you. That answers a couple other questions that were in there. One question I think maybe represent how a number of people feel is, what is required to practice safely in the community? So if you're a community physician, a community doctor, and you're seeing patients, what would be the recommendations to practice safely?
Yeah. So I feel very badly for community-based docs because PPE has been so hard to come by. The ideal recommendation, of course, is that well, there's a hierarchy of controls for an outbreak. There's a hierarchy of controls for any safety thing, and the first one is avoidance. So if you could go back in time and make the pandemic not happen, that would be how you would address that. Of course, that's not possible. So the next layer down in the hierarchy of controls is substitution. Substituting virtual visits for in-person visits. And I really do strongly encourage, as much as possible, you do take that up. We certainly have made that part of our practice, is that we're doing phone call and or OTN invite-based visits for as many patients as we possibly can in infectious diseases. And I'll tell you, it was a real struggle. We do a lot of wound care work, which requires a direct review of wounds and hands-on manipulation, and we've had to back off on that. Thankfully, so far, there haven't been any major consequences of doing that, although you could imagine that it's still possible there might be. We have been doing a smaller number of in-person reviews than we normally would. To put that some numbers on that, our STIC clinic, skin and soft tissue infection clinic at the Queensway Carleton Hospital, typically sees, I would say, 200 patients a week in person. We're now seeing something in the area of 50. My colleagues are disagreeing with me. Okay, doesn't matter.
Doing the questions on the side, that's all.
Oh, I see. Right. So substitution. And the next layer down is engineering control. So putting in things like plexiglass partitions at your clerk's desk so that they are well protected from droplets from the patients. And finally, PPE. PPE is actually the lowest level of protection after these other ones have already been put in place. So hard as it is to get PPE, it's relatively simple to get a sheet of plexiglass. So you might be able to put that, for example, at your administrative assistant's desk, and now you don't have to give your admin PPE. You can preserve the PPE for that in-person encounter in your exam rooms where it's more necessary. You should have a fluid-resistant procedure mask. You should have eye protection, which can take the form of either a visor mask, those are hard to come by nowadays, or a full face shield. And there's an excellent Facebook group, if anyone is not aware of it, called Face Shields for Docs, I believe. I actually am led to believe they're going to be wrapping up in the near future, because they feel they've actually provided face shields to quite a number of docs. So it could be the last few days to be able to get one of those, or even something as simple as a pair of safety goggles, as long as it wraps around the side so that side entry of droplets is prevented. You should have a gown, preferably what we call a level 2 gown, which is partially fluid resistant, and you should have gloves. These are all shouldas. All of these things, every single one of them is in short supply. Not quite as critically short as the N95 respirators have been, but they are in short supply. And substitutions may need to be made. So for example, if early on in this pandemic you bought yourself an elastomeric full face respirator, which some of my colleagues did, so a gas mask basically, you could potentially use that even though it's overkill, but you have to have a cleaning procedure. You have to, after every use, you have to be able to wipe it down with soap and water, and you have to be able to clean it with some kind of virucidal product. Alcohol works. Coronaviruses are actually relatively easy to kill. One of the things we're doing in hospital, and it's certainly worth considering in your practices as well, is prolonged use, especially of masks and eye protection. So a good combination, for example, would be to put on a fluid-resistant face mask and a full face shield and just leave it on all day. And at the end of the day, clean the face, the full face shield, and dispose of the mask.
Thank you. We have there's a few more questions here. We only have a few more minutes left, so I'm going to try and group them together. There was a question specifically about how to address surgeries. We have developed an algorithm that the surgeons and the anesthesiologist and the surgical nurse, the lead surgical nurse, can use to identify which bucket or which PPE should be used in that particular instance. And I will share that with the group. It's already been shared through our acute care group, but we'll share it more broadly to adapt to your own situations. There is a question about pregnancy, and one of the future talks is actually going to be COVID and pregnancy. So I'm going to save that question until we, until that talk where we have the gynecologist or the expert in that issue come and discuss to us. And so I'll leave two different types of questions. And the first is for Dr. Sharma. One of the slides indicated two different strains of the COVID-19 that had two different levels of virulence. I wonder if you can just provide some brief comments on that.
Yes, these were originally the L and S strain. L was supposed to be more virulent and S was less. L was initially present in Wuhan, but since then I've actually tried to look for further information regarding this, and I can't find anything else. So I don't know, what variants that are circulating around right now, and I'm sure somebody out there is doing some further analysis. But post Wuhan, we don't have much information as to what strains are circulating.
Greg, did you want to add anything to that?
Oh boy, the L and S strain thing is actually pretty controversial. They were stated to be separate strains. I mean, there's definitely genetic differences. I think at this point they're actually talking something in the area of 4 to 6 clades of this particular virus, but I don't think there's been any good empiric evidence that there's a real clinical difference between any of them. If I can riff on that just a little bit, I'm often asked about what will happen if this virus mutates and becomes much more virulent. Honestly, we don't know. This would be what we would term a black swan event, just as the emergence of this infection in the first place is a black swan event. It would be very hard to predict possible outcomes from that. In past pandemics, there often has been a mutation to either become more or less virulent after several months, and I could not tell you which way this would go.
The last group of questions are all centered around community protection, just generally speaking, with specific questions about kids and going back to school. And there's two questions in there that I think I'm going to pull out and extract. Is one, what are the general recommendations when you're going out in the community with respect to type of mask? And secondly, with respect to kids, are kids really asymptomatic carriers? And the other thing, regarding, there's a lot more questions that will start out. Are they asymptomatic carriers, and what is the risk for children getting sick? So I'm packaging 3 questions into that.
Who would you like to answer them?
Whoever wants to.
Well, I'll start then. So as of last week, the Provincial Health Agency, pardon me, the Public Health Agency of Canada has recommended that regular citizens in their day-to-day activities should probably wear a non-medical mask in public. And I think, you know, I've struggled with this one myself. I actually, I've been working with a group of medical students to do a systematic review of cloth mask wearing and its protective effects. And it's not terribly effective in comparison to a procedure mask. However, there is, depending on the weave of the fabric, there is actually a reduction in the amount of production of droplets. We know that cloth masks, for example, were used quite successfully as surgical garb to reduce the likelihood of droplets getting into open body cavities 100 odd years ago. And there's certainly a benefit. It's one of those things where there's probably an incremental effect if everyone was doing this, in addition to generally trying to avoid public, in addition to generally, you know, being a little bit more careful about monitoring their health status, it would be beneficial. Certainly, hand hygiene, critical. I hope that people are already on board with the idea that gloves are not a great idea in public. And I liken it very much to condoms. You would not wear one from place to place or person to person, and therefore wearing gloves from place to place and person to person is a fairly poor idea. But hand hygiene is a great idea, and if it's possible, given the shortages of alcohol-based hand rub, if it's possible to have one that you bring with you, that's a very good thing. Things like picking up groceries and washing down the bags and, you know, draping yourself in plastic, these kinds of activities are much more effort than any benefit you might get out of them. But hand hygiene and a non-medical mask, it's a great idea.
And why don't we just move to in terms of the asymptomatic carriage amongst children, the specific context is, should schools be delayed, summer camps, should children participate in those outdoor type activities? And I'm inferring 2 questions. Is one is, are they really carriers? And 2, what is the risk to children themselves?
Right. So, yeah, I'm going to answer the second question first. The risk to the children themselves of death from actual classic COVID-19 is fairly low. We've not had any mortality in children in Canada, and worldwide we're talking like single-digit numbers. It's very, very low likelihood that a child is going to become ill from the acute infection itself. This concept of an inflammatory mediated post-coronavirus syndrome in children resembling Kawasaki's is certainly concerning. It has not been proven to be actually directly associated with COVID, but the temporal association in places where there have been COVID outbreak and then followed by an increase in COVID toes and Kawasaki-like disease certainly suggests it's a possibility. I'm not a pediatrician, so I really can't give you the numbers on that. The first question I'm also going to kind of punt as well, because I know that there is a preprint that's become quite popular this week in conversation in social media circles about the idea that children are not asymptomatic carriers and they are not spreading this infection. I don't know the article. I haven't read it. I think it strikes me as unlikely, knowing what we know about coronaviridae in general, and certainly it seems unlikely given the fact that there have been kids who have been picked up in the Wuhan investigation, but I can't comment on it directly.
Okay, thank you. Karen, do you have any other further comments on that?
No, I agree with Dr. Rose.
Okay. Everyone, I know there's about another 3 or 4 questions in here, and just in the interest of time, what I'm going to say is that for those questions that are outstanding, I believe we'll be able to collate them and we can send you a response over the next few days, just so you have, excuse me, just so you know that you've been acknowledged. It is 6:33 now. We are a bit over time, and I know that people have been stretched. I'd like to thank Dr. Sharma and Dr. Rose for their talk, and I'd like to thank all of you out there who took the time to attend today, especially if you submitted any questions. Going forward, as mentioned, this is an ongoing series of talks related to COVID. Future talks will include the impact in terms of PPE and surgeries. It will include the obstetrics and pediatric components. And given the changes in Directive 2 about opening up DI, ambulatory care and whatnot, I suspect that we're going to have talks related to those issues as well.
Sorry, Dr. Varghese, can we, next week in your email, I just sent you the speech for next week is COVID-19 and palliative care.
Yes, sorry, thank you. Thank you for reminding about that, Excel. So yes, so COVID-19 and palliative care, a very, very important issue, particularly if we do ever hit that second wave that we're all anticipating. Okay, with that, I will leave things. Take care and have a wonderful night and a great weekend.